On the approach to the clinical examination of abdomen, case carcinoma stomach, I call upon Professor Dr. Alex Edwards, sir, Professor of General Surgery, Sri Moogambiga Institute of Medical Science, Dr. Angeline Vincent ma'am, Associate Professor, General Surgery, Kanyakumari Government Medical College, Dr. AJIN MANOVAH, sir, Assistant Professor of General Surgery, Kanyakumari Government Medical College.
You are all very fresh and enthusiastic, and you had a very nice time, nice period with Dr. Dayananda Babu. I think you know about him, and I thank the chairpersons, and above all, I welcome all the students. I hope you are all in the final year or pre-final year? Final years. So, as you all know, abdomen is a magic box. Abdomen is a magic box. So, you have to have a good approach towards the examination of the abdomen. So, never ask any of the patient to stand and palpate. You should never do that. So, we used to have in our consultation room, patient will come there, patient will stand, and doctor will palpate, put his hand over his abdomen and tell that you are having a big abdomen, something like that. You will not be able to take anything on standing. So, always you keep the patient on lying posture and examine. And one more thing I want you to get corrected, and I think Jailal and the surgical faculty here are excellent people. They teach you well, and we are not supposed to see the investigations first. So, whenever a patient comes to you, what is your first duty? You have to ask what is given in DAS. And again I am reminding you, you read DAS, DAS and only DAS. This is considered to be a Bible of surgery, or a Quran of surgery, or whatever it is, or Gita of surgery. So, you have to read DAS, DAS, only DAS. And I need your attention to read initial first 4 chapters in DAS. So, that will complete your UG examination as well as PG examination. And previously the UG for case presentation and PG for discussion. Now, it's all changed. And now even today the PGs are supposed to present properly. So, the presentation is has to be good. For that you have to understand what is there in the abdomen. Abdomen, I told again, it's a Pandora, it's a magic box, we do not know. I may tell it's a retroperitoneal swelling, and on opening you will see it is an intraperitoneal swelling. So many things are there in the abdomen. So, I need your attention to examine a patient properly, and again I am reminding you, when you become a house surgeon, hope all of you will become a house surgeon in the next future, and you will be having your exam in March probably. March or late April, early April, we do not know. Most probably you will be having your exams in March. So, after becoming a house surgeon, so immediately what is happening outside, and in my same institution I am telling. So, whenever a patient comes, he or she will bring a bundle of investigations. Up to PET scan they will bring, FDG PET they will bring. So, immediately what is our anxiety, our aim is to read the investigation first. So, most of the times you will be getting failed in the clinical examination. Your mind will be fixed. Suppose they have written as appendicular mass. So, your mind will be fixed to the appendix. Maybe it's a cecal growth. You do not know because you don't examine. You see the images, and finally at the end of the report they will write, please correlate clinically. என்ன அர்த்தம்னா, டேய் idiot, நீ clinical examination பண்ணு, then you send him for investigation. So, that is the first thing you have to do, and you will have to learn in your practice. Always you examine a patient, come to a provisional clinical diagnosis, then you confirm your diagnosis with your investigations. So, only the investigations to support and confirm your diagnosis, not to make a diagnosis. So, difficult things like intrahepatic problems and the retroperitoneal and the some pelvic vague tumors and all may be very difficult clinically. So, by and large you have to examine the abdomen and you come to a diagnosis, and I request you to spend more time on what examination, inspection or palpation? Inspection. Abdomen always inspection. You spend more time. For the abdominal cases will be kept as a long case for you. For the long case, what is the time limit for long case? 45 minutes. So 35 minutes you have to examine, come to a diagnosis, then write a differential diagnosis. The definite diagnosis is not possible. Then you write the investigation and the treatment. All these things you have to write in a case sheet. That you take about 10 minutes. So 35 minutes you finish, and in the 35 minutes after history taking, you spend minimum of 5 to 7 minutes for inspection. So look at the abdomen. So there are a lot of things will be picked up. So I'll try to go through. So you all know this. This is a basic thing. 9 quadrants, and one more quadrant. You know, it's a 10th quadrant is a external genitalia. So like the breast swelling or chest swelling, axilla. Axilla is a hidden area you have to examine. Then the neck, oral cavity. The neck examination is incomplete without your oral examination. You have to open and see what is inside the mouth. Then here also examine axilla. Without examination of the axilla, your breast examination incomplete. Like that, abdominal examination is incomplete without the external genitalia examination. These are all the quadrants. I think you know about that from the first clinical onwards, the 9 quadrants, 2 arbitrary lines, and divide the abdomen into 9 quadrants. You all know that, right? Hypochondrium, epigastric. I am not going into the detail. These are the very basic things you should know. What I am trying to tell now, emphasize, is the 10th quadrant is very important. So you have to examine a patient with adequate exposure, not stripping the patient. Some used to tell in the examination, I will strip the patient. You are not supposed to strip anybody, right? So your examination area should be adequately exposure, whether it is a neck or breast. Somebody will hesitate to show their neck, especially some communal issues. So you have to have an adequate exposure, and you have to see up to the mid thigh. How do you examine the abdomen? The nipple to the mid thigh, especially the inguinal region and the external ring area. That is there is a hernial orifice you will see. These are all the 9 quadrants. And when you come to general examination, no examination is incomplete without examining the general examination. So general examination, I will write one or two things only. You just make a note of it. You have to see the nutritional status and whether the patient is paler or patient is anemic or jaundiced, icterus. So the patient is, that standard teaching, when you want to examine for jaundice, you ask the patient to look down and see the upper palpebral conjunctiva, right? Okay. So anybody is asking, how do you look for the early jaundice? That is, early jaundice clinically, early, and what are all the clinical types of jaundice? Anybody? Clinical types of jaundice: mild, moderate, and gross or severe. So mild jaundice, your serum bilirubin level should be at least 2.5 to 3. Then only you can have a clinical jaundice, right? Ask the patient to look down. You see the upper palpebral conjunctiva. Now what about anemia? Ask the patient to look up and watch the lower palpebral conjunctiva. These are all the 3 things commonly they are asked. I think you are very well aware of that, because you have got excellent teachers like Selvin sir, Almano and Angeline madam, and your boss is there in the next room, next hall, and Nixon, Joshua, so many faculties, Edwin. So it is embedded with right, diamonds and precious stones, right? So this is how you like to examine and look for the jaundice. And I am thankful that these people are my students. Nixon, this thing and all. So there was, if there is adequate time, I will tell one small example. So we had a get together at Travancore Heritage. So one farewell party for Dr. Parimalam, who was my teacher, and that time he was doing first year MS. So that time people asked. So I was the head of the department in that time, Presided Medical College. Everybody was asked one question: what is your what do you want to do? What is your will? What do you want to do now? And he will tell that I would like to sit on the lap of my HOD. In Travancore Heritage. And I think still I have the photo of Nixon sitting on my lap. Thank you, Nixon. And I have shown to my children also the same thing. So thank you. So it's very, very nice. Tirunelveli, it's like a family. And here also, when Jailal and your faculty, wonderful members like Selvin sir and AJIN MANOVAH are there, so it will be like a family only. So we are in a family, because the surgeon is always a tenseful job. If you do a thing wrong, it will be flashed in the paper and you will be looked down by the officials, by the public, and when you are going up, nobody will bother. Okay, so people would like to fall down. So when you are becoming better, nobody will appreciate it, even in your institution, right? So this is a general examination, the must. You will have to look for the jaundice, how you look for a jaundice, and how you look for anemia, you should know. Then pigmentations, right? Then mental status. These are all the roughly about the general examination of the patient. Coming on to the quadrants, I have already told about that. So there are some book you see there are regions. There are regions, upper outer, four regions: upper outer, upper inner, lower outer, lower inner, and totally there are 13 regions. Anybody? 13 regions. What are the 13 regions? Inga or 9, then your back, then supraclavicular. 9 plus 4, 13. So just to remember, not to just to make aware that these are all the things you should not forget to examine. Right? So whenever there is a case in the lump abdomen, or you make a secondary, or you make a primary, or carcinoma stomach, you have to look for the supraclavicular region for what? Which node, right? So all things you should not forget. So a surgeon should have an eye of an eagle, not an eye of a crow. Kaaka vandu oru 100 அடி 150 அடி மேல கண்ணு தெரியாது. Okay, so eagle can look from about 5 kilometers, 7 kilometers. So like that you will have to see. You will have to examine a patient as a whole, not a particular area. Some of the patient is having diarrhea of unknown cause, unless you know that hyperthyroidism may produce diarrhea. You have to have an eye of an eagle. So you will have to examine properly and investigate, right? So this is all inspection. I told again, you have to spend more time on inspection of the abdomen. So you have to be patient. So நம்ம எப்பவுமே இதுதானே the fast food world, அப்படிதானே? Fast food, the shops and all, now you stand and take food, and Madaram fast food, this thing and all, on the roadside there are so many fast foods. உடனே கடகடான்னு இறங்குறோம். இப்போ வந்து one of the TFE faculty, they went to take idli. அப்போ என்ன பண்ணுவாங்க, உட்காந்து சாப்பிட்ற டைம் இருக்காது. ஸோ we are in a rush world. So we have to examine that also. Like that also our tendency, கடகடான்னு போகணும். என்ன பண்ணணும்? Don't look at the abdomen. சார் சொல்லிட்டாரு படுக்க வச்சு. ஸோ you ask a patient to lie down. கடகடான்னு அந்த சப்பாத்திக்கு மாவு பசைவாங்கல்ல, அந்த மாதிரி you palpate the abdomen. இங்கே இருக்கு, liver மாதிரி இருக்கு, spleen மாதிரி இருக்கு, abdomen மாதிரி இருக்கு. No. So that is a thing you should never do that. So be patient. You have got 35 minutes in the examination, and in your life you have got more number of hours and minutes. So spend little time. So another thing, patient will be very happy. Doctor has seen my abdomen and palpated my abdomen, examined thoroughly, and send the investigations. So if you palpate properly, you elicit McBurney sign, and you send the patient for the examination or ultrasonogram or CT or whatever it is to confirm your diagnosis, and you can commit the patient. This looks like appendicitis because you have got McBurney sign. I am doing the investigation to rule out other causes like distal urinary calculus or something like that. So patient will have a trust on you. So what our doctors, our people, after MBBS, you tell, என்ன பண்ணுவோம், lower abdominal pain இருக்குனா, you go and take a scan. You go and take a scan. Then I will tell. So what the patient will feel. He will go to the scan center. இங்கே நம்ம குரு நிறைய scan centers இருக்குது, and they will write the probe tenderness, probably acute appendicitis. அப்போ scan center people have made a diagnosis. அப்போ என்ன பண்ணுவான், everybody is having an Android, they have got Google. அப்போ good surgeons in Tirunelveli, best treatment for appendicitis, and it will be written என்னது, emergency appendicectomy. So who is the best surgeon? Dr. Selvin. அப்படி சொன்ன செல்வின் சாரை பார்த்து போய் அங்கே ஆப்ரேட் பண்ணிவிட்டு he will come after 3 days, lab are open, 3-4 days கழிஞ்சு வந்து, சார் நீங்கள் சொன்னீங்க, நீங்கள் வந்து இது ஸ்கேன் எடுத்துகிட்டு வாங்க, நான் என்னென்னு பார்த்து சொல்கிறேன், என்னென்னு உங்களுக்கு தெரியாதனால தான். ஸோ people are very, they are very studious there. They will think that doctor doesn't know what is it. So he has asked me to go for a scan center. So he will get operated, come with a scar. So this is what happening now. Instead, you have to make a clinical diagnosis. So probably it looks like an appendicitis. So they will have that the doctor had a suspicion. So he'll go back and they will come back to Nixon and get it operated. So Nixon will get about 30 or 35,000 rupees in his pocket rather than sending a patient and getting a professional charges from the scan center. So that's again is not good. So you have to spend time with the patient, spend more time on inspection, look at his abdomen, and you have to do the examination properly in an order which is given in DAS. So you all have a DAS, I think, right? So the best book, never read anybody's note, right? Anybody's notes, professor's notes, நிறைய notes are being circulated. 20 பக்கத்துல notes இருக்குது. Long cases ஒரு notes, short cases ஒரு notes. Those notes and all you never read, okay? So what is the first thing in the abdomen you like to do is the shape of the abdomen. So what is the normal shape of the abdomen? Scaphoid or boat shape. That means there are 3 landmarks in the abdomen. One is a cephissedum, another is an umbilicus, another is a pubic symphysis. Very good. So these are all the 3 landmarks. When you call it as a scaphoid, that means boat shaped abdomen, your umbilicus should be at the lower level. That is called the normal shape. So umbilicus, cephissedum, pubic symphysis, all at the same line. It is called a flat abdomen. So most of our faculty and all, I have a flat abdomen or maybe a distended abdomen, right? So the third one is a distended abdomen. If you have any doubt, you keep a measuring scale. அதை வந்து abdomenல perpendicular இப்படி போடிங்கனா it should be the umbilicus at the lower level. Only few people will have a scaphoid shape. Nixon now we are having a flat abdomen, right? So I think he is very happy, he is well settled now. So abdomen will flat, and then after about 5 years or 10 years your his abdomen will become more than mine. So distended, right? So if it is distended, the umbilicus should be at the higher level. That is the normal thing regarding the shape of the abdomen. And the number 2, அது பார்த்துக்கணும் நம்ம முதல்லயே படுக்க வச்சு, if you have any doubt you keep a scale, right? So then movement with respiration, that is again a very important point. So whether all the quadrants move equally with respiration. Suppose one quadrant, like lower right lower quadrant not moving, other quadrants are moving, that means some pathology in the right lower quadrants. The common pathology is a appendicitis. Inflamed appendix will touch the parietal peritoneum, and the peritoneum is the most sensitive organ in the abdomen. So what will happen when the patient moves? Peritoneum will rub over that and it will be very sensitive and the patient will not move. So other quadrants will move. Like that what you have in a cholecystitis. Upper quadrant will not move. So spend little time with the patient. You watch his respiratory movements and the abdominal movements corresponding to his respiration, right? Then you see, look for a scar. When there is a scar, midline scar, usually midline scar or paramedian scar, so many scars are there, phalangeal scar. So phalangeal scar, this problem will not come, and the scars in the abdomen, especially the paramedian or midline scars, the abdominal scar, and you see a VIP or something like that, you are sure that there is a surgery being done, probably adhesive obstruction, that you have the dilated small bowel loops. So these are all the things that pick up. There are any scars, surgical scar or natural scars, then sinuses discharging some purulent material or pus or granules, and sinuses. Sinuses means there is a difference between sinus and fistula. I am not going into the details. And the distension of the abdomen, then prominent veins and position of the umbilicus. எப்போவுமே நம்ம our tendency, நாங்கள் எங்கள் ஸ்டூடெண்ட்ஸ் போடும்போது அப்படி சொல்லுவாங்க, shape of the abdomen, then umbilicus. Don't rush to the umbilicus immediately, right? So we are not bothered about the umbilicus because umbilicus position itself is variable. It can be pushed up or pushed down. So there are varieties of shapes of the umbilicus, and only the celebrities and the actresses are bothered about their umbilicus. We are not bothered, right? Okay. And young girls are there, and those people should bother about your umbilicus, right? Then stria, then bruit, like Cullen sign, great Turner sign. There are 2 signs, right? I think then peristalsis. So what is peristalsis? The movement of the bowel. You have got gastric peristalsis as well as you have got intestinal peristalsis. Gastric peristalsis, it will start from the left to right. The waveform, the waves will be high waves or medium waves or low waves. Waves will be prominent and it will be from above the umbilicus left to right. So, intestinal peristalsis near opposite, below the umbilicus, right to left, right. So, these are all the signs. Then position, size and shape of the swelling. So, this is the inspection most of the times I told already. So, abdomen is a magic box, you will not be able to get anything during the inspection. Very rarely you get a mass moving with respiration. So, whenever you see a mass, you have to see the position, which quadrant it is, then the extent of the mass. Suppose you should, the appendicular mass will be not in the right iliac fossa, isn't it? Appendicular mass usually invariably in our practice, it will be in the ilio-lumbar region. So, it is there extending on to the other quadrants, right. Suppose the epigastric mass, so the carcinoma of the stomach, it can extend on to the left hypochondrium, the right hypochondrium or to the umbilical region. So, you have to know much about may not be able to know much about the size, shape and the duration during the inspection. So, inspection, those are all the above things I told already regarding your shape of the abdomen, then your scars, skinus, VGP, VIP, any mass, then your what is that, your color change, any pigmentation, any bruising or all things you will have to pick up in this thing. And then you have to examine definitely the 10th quadrant. You have to see the hernial orifice in all cases of abdominal pain. Sometimes to your surprise, there will be a swelling in the hernial orifice which will not go into the abdomen normally on deep inspiration or expiration. So, that will give a clue. The patient is giving the complaints of vomiting, pain abdomen, vomiting, not passing stools or not passing flatus. What is the condition called? Obstipation. Obstipation. Very good. I think you all know well, you are answering well, very good, keep it up, right. So, obstipation, not passing stools or not passing flatus. So, then you touch, you are on the inspection, on palpation, if it is a irreducible swelling not getting reduced and patient is having a signs, symptoms of vomiting, this thing, tenderness. So, definitely it is a case of obstructed inguinal hernia. So, that has to be tackled immediately. That has to be tackled immediately. It's an emergency. So, all emergencies you have to examine, make a clinical diagnosis. So, this you do not need a confirmation. What is the confirmatory test or investigation for obstructed inguinal hernia? Anybody? 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 Then nowadays idalam kedaiyadhu po. So, plain X-ray abdomen erect. You will see dilated two loops with the air fluid level. Yesterday I was talking with my postgraduates. We had a case of the what is it, left sided chest as well as the abdominal left hypochondrium pain. So I asked him, what is your finding? Urinary diminished, tenderness in the left hypochondrium. What investigation you have done? So first answer was CECT abdomen. So there is a standard investigation you and me are writing now, never do that. What is the ideal investigation of choice in an acute abdomen or pain abdomen? X-ray, plain X-ray chest erect. Now we have a teacher, I had my head of the department, he is still alive now, Dr. Gobinathan. He taught so many things to us. Now either without taking an X-ray abdomen erect, you should not proceed with other investigations or treatment. So even acute appendicitis, you will get isolated the ileus like this thing in the right iliac fossa. So many things will be picked up by your plain X-ray abdomen. Plain X-ray abdomen, plain X-ray chest. Sometimes you will not be able to see air under diaphragm, you take a chest X-ray also, X-ray erect. Then movement with the respiration, right. So what do you mean by the movement with the respiration? The swellings, what do you see in the abdomen, on deep inspiration and expiration, it will move up and down. When inspiration, it will come down. What does it mean? Swellings, hollow viscous or solid organs which are below the diaphragm, inside the abdomen will move. So swellings behind the peritoneum or in the posterior abdominal wall or retroperitoneum structures may not move. Okay. So there is no point in their contact with the diaphragm or something like that. So always you keep remember when the swelling moves respiration, usually it will be intra-abdominal and intra peritoneal. Swellings which will not move with respiration will be intra-abdominal retroperitoneal. Example, carcinoma pancreas or para-aortic nodes. They are in the retroperitoneal structure. They will not move with the respiration. And kidney, will it move with the respiration? Kidney? Yes or no? There is a slight movement. Okay, undergraduate you tell no, but there is a minimum movement. Okay, don't bother about that. Right. Okay, this is a gastric peristalsis from the left to right, and the intestinal peristalsis from the right to left. That is called step ladder pattern. Step ladder patient, and you need minimum of 5 air fluid levels to call it as an acute intestinal obstruction. Then position of the umbilicus, we all know there is usually it has to be in the midway. இருக்காது ஒரு லாப்ராட்டமி பண்ணா ஒரு LSCS பண்ணோம்னா the patient becomes pregnant and all, and you will not see the umbilicus in the position. What do you have to look at the abdomen, whether it's everted? What is the normal shape of abdomen? Inverted. So if it is everted or flushed, that means the abdomen is distended, right? And you look for any sinuses in the umbilical or any scar in the umbilicus or whatever it is. And the umbilicus is a very it's a beautiful structure in a female, not a male. நம்ம அதை பற்றி பாதர் பண்ணுற கிடையாது. நம்ம அம்பலிகஸ் சிலவங்களுக்கு எங்கே இருக்குன்னே தெரியாது. So some people will not be able to see their own umbilicus. வயர் இப்படி இருக்கும். Wire will be on the knee. How will you see the umbilicus? You won't be able to see. Okay. So other advantages of what are the other surgical importance of umbilicus? Anybody? Umbilicus has got no underlying support. It has got no underlying muscle, no underlying fascia. What is the important structure which is getting attached to the umbilicus posteriorly is the parietal peritoneum. அது மட்டும் தான் இருக்கும் அதில் ஒட்டி. And you cannot separate the parietal peritoneum from the umbilical scar. So the mother has left us a mark, that is an umbilicus. What is the surgical importance? Pardon? That is surrounding the umbilicus. You know who is Sister Mary? She is from Kanyakumari Medical College. From where? America la engappa? John Hopkins, Mayo's Clinic. Yes, very good. So umbilicus surrounding, you got a Sister Joseph nodule. I am talking about the umbilicus. In the umbilicus, surgical importance, easy entry. So you want to enter easily. You know, NEET exam illama easy entry எப்படி? எங்க போய் குஜராத்ல போய் question paper வாங்கிடுறது. There is a easy way of entering the NEET. You know, yesterday somebody was caught in the விழுப்புரமா சிவகங்கை மெடிக்கல் காலேஜ்ல எங்கேயோ. One fellow was joined with the fake NEET certificate yesterday or day before yesterday. So the things are all happening as usual. So easy entry into the abdomen is the scar. There is the umbilicus. Through the umbilicus you can enter. So many surgeries will be happening. Single port surgery. In a single port surgery என்னன்னா நம்ம appendicitis பார்த்துருப்பீங்க, 2-3 போட்டு உள்ள கொண்டு போய் எடுத்து பண்ணுவோம். This is a single port. Through the abdomen you can put a port. Okay, single port, side viewing cameras அதெல்லாம் இருக்குது, instruments இருக்குது. You can do the surgery with a single port. அப்புறமா கடைசியில் என்ன ஆகும்? They will close the umbilical incision. You won't see any scar. The umbilicus itself is a scar. So problem is a healing. Umbilicusல என்ன ப்ராப்ளம்னா healing, because blood supply in the umbilicus is less comparatively because it's a scar tissue, as you all know that. Then canal sign. Anybody? Downward or upward? Okay, depending on the pathology. Right, very good. I think you are doing well. You don't need a CME or something like that now. So you can straight away go to the examination. The hernial orifice, I have already talked about this. Then this is a beautiful diagram which is given in what book? MANOVAH. Illa, DAS. This picture is there in DAS. எத்தனை பேர் பார்த்துருக்கீங்க இதை? DAS நிறைய பேர் திறக்கிறதே இல்லை இப்போ. Okay, எங்கள் பிஜிஸ் எல்லாம் DAS வந்து சப்ஸ்டாண்டர்ட் புக். That is a gold standard book. Okay, நீ வேற எதுலையாவது மாலிகுலர் பெத்தாலஜி அது ஜெனட்டிக் பெத்தாலஜி கேட்டாங்கன்னா சொல்லலைன்னா பரவாயில்ல. So something is asked from the DAS, right? Then if you blink at the examiner, 2 தடவை blink பண்ணலாம், 2 தடவை you can tell that, sorry sir, what is the best way of answering if you do not know the answer? Sorry sir, I am not able to recollect. What does it mean? I have already studied but not able to recollect now. So that is a false statement. Would have never studied that portion, but you will tell, sorry sir. தமிழ்ல அப்படி சொல்ல முடியாது இல்லையா? தெரியாது சார், தெரியாது. ஸோ மறந்து போச்சுன்னு சொன்னாச்சுன்னா the examiner will ask, what is your age? 22. At 22 years of age, you forget everything. You forget your name of your wife. Yes sir, frequently sometimes we forget our wife's name also. So There is other side. So this is the examination of the general examination. I told you, you have to have an eye of an eagle. So whenever there is a swelling in the scrotum, hard swelling in the scrotum, and a mass in the abdomen, the epigastric region, automatically you look for the supraclavicular lymph node, right? So you have to examine all the three places, and if it is a GA malignancy suspect, you look for the Irish node in the axilla also, right? So these things you should have a proper general examination of the abdomen. These are all the portions which are included in the abdomen. What is Trocheus sign and what is Trochea sign? I think you all know that. My time is running fast. So this is a palpation. Now you come to the palpation. You come to the palpation. And some people have the eager, there is a mass in the epigastrium. So it is our tendency. அப்போ போகிற இடத்துல வந்து வெஹிக்கிள் எல்லாம் நிப்பாட்டி வச்சுருக்காங்க, அண்ட் 108 நிற்குது, இது அடிக்குதான், சைரன் அடிச்சிட்டு இருக்காங்க. வாட் இஸ் அவர் டெண்டன்சி? உடனே வண்டியிலேருந்து இறங்கி what is happening there? Okay. So like that, when you see a lump or mass in the abdomen, it is our natural tendency, put our finger inside and see. அப்படி என்னென்ன ஒரு பாத்திரம், அதுக்கு பிறகு இன்ஸ்பெக்ஷன், அதுக்கு பிறகு ஹிஸ்ட்ரி, அதுக்கு பிறகு நேம் ஆஃப் த பேஷண்ட். நோ, that you have to have a systemic examination, right? Now you go to the palpation, you look for the local temperature. If a local or swelling இருக்குது, if there is a swelling and you palpate, it is warm in temperature. Few things you have to do on palpation. One, all your inspectory findings to be confirmed. Not only this, any other swelling or any other ulcer. So all your inspectory findings to be confirmed. Number two, whether it is warm or not. Number three, whether it is tender or not. Number four, it is movement with side to side mobility or thyroid nodule side to side or up and down movement, right? Then consistency of the swelling, whether it is cystic, firm or hard or bony hard. So all things are there in this thing, and you have to examine for the tenderness, whether it is tender on palpation. So if it is tender on palpation, probably it's an inflammatory sign or in the late period of malignancy. And the margin, all the margin should be examined carefully with your palpating finger. So the gallbladder, you will have to pay the right side of the gallbladder, right margin, left margin, low margin, and upper margin. You will not be able to palpate the upper margin because it is attached to the liver and goes into that. So these things will have to be. Suppose if the mesenteric cyst, you can see palpate all margins, above, downwards, movement, along the line of the attachment of the mesentery. So margins, and the margins are indistinct. Then you have to think about malignancy, right? Then this is a consistency. I told already there are 3-4 consistencies: soft and cystic, then firm, hard, bony hard. Bony hard only the bony swellings. And you look for the fluctuation. Fluctuation, you have to use 4 fingers, 2 are observing fingers, 2 are examining fingers. Suppose the swelling is small swelling. What is the method of palpation in a very small swelling? Pages. Very good. I think you all, you can give a pass to all of you, right? In a, sir, madam, in the batch எல்லாத்துக்கும் pass கொடுத்துருங்க, right? Okay. And they are doing well, excellently well, right? So movement of the organs, I told already, intra-abdominal, intraperitoneal organs will move with the respirations, or swellings or solid organs which is below the diaphragm will move with the respiration. அதனால தான் என்ன சொல்கிறாங்கன்னா, இப்போது nowadays நம்ம பீரியடில் வந்து knee elbow position. So there are 3 planes in the abdomen, if you are agree. One is a parietal. You do a cornet test or head raising test, the swelling becomes less prominent, it is intra-abdominal. Then intra-abdominal, there are 2 planes. One is intraperitoneal and retroperitoneal. How do you differentiate? Knee elbow. So knee elbow, last symposium and all, now I think in Western countries they don't do knee elbow now. So it is a cumbersome procedure. Knee elbow அப்படி பேஷண்ட மாடு மாதிரி நிற்க சொல்லுவோம், 2 கை 2 கால், போயா வேண்டாம், எக்ஸாம் வேண்டாம், நீ ஒன்றும் கண்டுபிடிக்க வேண்டாம், பார்க்க வேண்டாம். Like that people will tell. You know, they are very educated people, and especially people above 60 will usually will have osteoarthritis. நமக்கெல்லாம் இப்போவே முட்டு மடக்க முடியல. ஸோ எப்படி மடக்கி குத்த வச்சு கை வச்சு, இட்ஸ் டிஃபிகல்ட். ஸோ வாட் they say, swellings which move with respiration will be intra-abdominal and intraperitoneal. So anyhow, you know the theory, there is a knee elbow position, and the knee elbow position போடும்போது you will look for a mild ascites, that is called the pedal sign, right? percuss around the umbilicus. So, parietal swelling, intra-abdominal swelling rendu, intraperitoneal and retroperitoneal. Intraperitoneal swelling, all the intraperitoneal swellings will move with the respiration. Intra-abdominal retroperitoneal swellings will not move with respiration. Okay, so epigastrium is a huge mass, doesn't move. So what does it mean? It could be probably a paratic node or whatever it is. It is a retroperitoneal swelling. So you spend little time with the patient, you can pick up a lot of things in the clinically, right? So palatability, you all know what is palatability. This is for the direction of the movement. So always, where do you palpate? I forgot to tell. There are two methods of palpation. You all know. One is a superficial method, and another is a deep method or dipping method. Superficial method na enadhu superficial ah paakradhu. நம்ம கிளாஸ்மென்ல புதுசா ஒரு பொண்ணு ஜாயின் பண்ணிருக்கு. எப்படி பாப்பா முதல்ல மேல ஓட்டமா நல்லா இருக்கு பாப்பா நல்லா ஓகே ரைட். And then you go into deeper palpation like what is her community, what is her father, பிடிச்சாலும் பிடிச்சோம் ஏற பிடிக்கணும், புளியங்கொம்பை பிடிக்கணும். என்ன பிடிக்க கூடாது, முருங்கை கொம்பை பிடிச்சா என்ன ஆகும், புளியங்கொம்பை பிடிச்சா you can swing throughout your life, right? So palatability, so beware of all your young looking girls, good looking girls, the boys be careful. Then palatability only for renal swellings in the lumbar region. Palatability on the lower thing should be a muscle or something, it should not be a bone. So you cannot do a palatability in the gallbladder swelling or in the pelvic swelling, right? So நான் இப்போ ஏற்கனவே சொல்லியாச்சு கார்னட் டெஸ்ட், parietal, intra-abdominal and intraperitoneal, intra-abdominal, retroperitoneal. Then this is the expansile pulsation. You took the diagram, the transmitter pulsation and expansile pulsation. This is expansile pulsation. The pathology is in the vessel, aorta. Other one is a transmitter. It transmits the pulsation, right? So if there is a swelling in front of, anterior to the distended aorta or something like that, it will expand, right? Then insinuation is very important again. Insinuations are finding you are able to put your fingers between the swelling or the organ and the costal margin. If the insinuation is not possible in the abdomen, it probably is a common swellings which will have negative insinuation is a liver and left side you have got spleen. So this is a method of palpation. The palpation also you have to stoop down at the level of the patient. சின்ன பிள்ளைகள் எல்லாம் கீழே படுத்திருந்தாங்கன்னா எப்படி palpate பண்ணணும்? You have to lie on the floor and palpate, right? Your hand should be, the தாஸ்ல ஒரு படம் போட்டுருவாங்கல்ல, 90-degree palpation is banned, should not do. You have to do a parallel to the anterior abdominal wall, you put your finger and palpate. Be careful, right? Then palpation of the liver, always start from the right iliac fossa, you slowly right lumbar region, suppose the liver will be in the right iliac fossa, you don't know, massive hepatomegaly. So watch the borders, consistency, all things, movement with respiration, right? So insinuation may not be possible. Then liver span, you have to look for the liver span. So this is a middle maneuver or hooking. Edukku spleen. Idu onnuku da you stand on the left cephalic end of the patient and hook, try to hook or area between the spleen and the costal margin, right? There is fluid thrill, you all know, mild, moderate, mild pedal sign, moderate என்ன பண்றது, shifting dullness and gross fluid thrill. Yes, this is the way you percuss. Only use the middle finger and tap. மொத்தம் ரிஸ்ட்ல இருந்து போட்டு அடிச்சு தாக்கிர கூடாது. Patient will get a fracture or something like that. Okay. So the solid organs will have a dull note. Right. This is a top space. You all know about that. I am not going to the details of top space. Right. So the Nixon method of palpate. What is Castell's point? Shifting dullness. Then auscultation. You look for the bowel sounds, right? And the circumumbilical region, you will have to look for the umbilicus. And the silent abdomen in surgery is very dangerous. It means it is a generalized peritonitis. Silent abdomen. So this is the homework for you. You can inform Selvin sir. So this quote I would like to tell. So you have to have a challenge in every day. When there is no challenge, you will not improvise your technique. So always keep a challenge. In a challenge, in the mudichodana you go for MS. That is a challenge in front of you. So you finish all your course, your this thing, and I wish you all the best. and make sure that you will all clear the examination in a flying colors. Thank you so much for the opportunity and thank you for listening. If you want any questions, you can ask after the inauguration. Thank you.
So we'll have the case discussion after the inauguration.
Immense pleasure to welcome our Medical Superintendent Sir, Dr. Y. Kingsley Jabasing Sir. We also welcome our ARMO, Dr. Vijay Lakshmi Ma'am and Dr. Renimol Ma'am. Grant me the strength to help my patients and their families, the skill to ease their suffering, the understanding to diagnose their needs, the kindness of heart to care for them and reassure their fear. Please be beside me on each and every case, on you, the greatest of healers. Amen.
Beloved and distinguished Dean of this prestigious medical college, Professor Dr. Ramalakshmi Madam, the Medical Superintendent, the Vice Principal, the distinguished faculties from different parts of our country, our RMOs, ARMO, and my own colleagues and my dear children. It is indeed a great privilege for us to have this program of SCALPEL 24. And in fact, I must thank the final year student of our Kanyakumari Medical College because they are the one who has initiated this. And they came and asked that we should have a program for, sir, most of the programs you are doing for a postgraduate, so the program should be there for an undergraduate. And they only compelled me to organize this program, so I must personally thank them for initiating this thought of organizing this undergraduate program. And I'm extremely happy that our beloved Dean was so kind enough to permit this, and he has helped us to have this both the hall for organizing this meeting, and so generous enough to come in our traditional pink color to make this event a great function. So on behalf of the entire medical students and fraternity, we welcome our Dean for coming for this program. It is always as a pleasure that in our Kanyakumari Medical College, the team of administration work as a team, and our medical superintendent, the vice principal in charge, the RMOs, ARMO, and all the faculties, all are working as with the positive vision and positive improvement of our college. We are working, so it is our pleasure that we have in our midst the medical superintendent, the VP, the ARMOs, RMOs couldn't come. So on behalf of our Medical College Department of Surgery, we welcome all our administrative people. The great honor is we are having leading professors from the different parts of our state and the different parts of our country. We have Professor Dr. Alex. He was a professor and HOD of Tirunelveli Medical College, now serving as the professor and HOD in the Mogambique Medical College. It is always a pleasure to work with Dr. Alex. So on behalf of Department of Surgery, we welcome you, sir. Professor R.C. Srikumar is a vascular surgeon and professor of surgery in Kerala, one of the leading vascular surgeon, and is a very important teacher in most of the PG clinics in the teaching schedules of our postgraduate clinical teaching on online. He is one of the very active participant, and it is a pleasure because being a vascular surgeon, we wanted to have the topics on the vascular surgery to be covered by him. So all the way from Trivandrum, he has traveled and come to this meeting. So on behalf of the Department of Surgery, we welcome you, sir. One of my privileged colleague, junior from the Tirunelveli Medical College, now one of the internationally renowned vascular surgeon, serving as a professor and HOD in the Mogambique Medical College, is Dr. Punithan. It is always a pleasure to be with you. Sorry, Karakoda Medical College. Karakoda Medical College. So it is always a pleasure to have Punithan for his that is paroxysmal spontaneous laughter, which we get when we are together as an examiner. So it is a great joy. So, and incidentally, most of you may know Papi Punithan, who was a medical gastroenterologist here, and Punithan is her husband. So we welcome on behalf of the department Dr. Punithan. Another very senior professor who has been just talked to you, it is one of always, we say the fatherly figure in the Department of Surgery is Dayananda Babu professor. He is a very leading person. His books on the surgery is well famous, read by the postgraduate across the country. So we are fortunate that he has spent time, is ready to be with us today. So he is now on class with the opposite side. So we welcome Professor Dayananda Babu. So we are Professor Babida, the HOD of the Tirunelveli Medical College, and Professor Rajkumar, the Associate Professor in Tirunelveli Medical College, will be joining with us. Similarly, the Professor and HOD of the Thoothukudi Medical College, Dr. Rakesh Fernando, and the Professor in Thoothukudi Medical College, Dr. Nirmal, will be also joining with us. So I take this opportunity to welcome them. But most importantly, it is our department faculties, Professor Dr. Angeline, Dr. Selvin, and all the assistant professors. They have done extremely good job, coordinated and organized things in a team effort, and that is a great joy for our department. We always work as a family, and they have once again proved that as a department of surgery, as a family, that we have done this. My credit goes to my own postgraduates. They are the backbones or the pillars of organizing this program. It is always a pleasure to have our MEU, Madam. I admiring the professor for the vision, the interest, the enthusiasm she has is tremendous. So we Department of Surgery, we welcome you all, Madam. So thank you very much for this opportunity. As we have said, because we do not want to make this as one of the fun-filled area, but this is a intensive academic learning. So that is why we are starting from 8:30. It may go up to 6 o'clock because all the cases we will have a discussion. So in the undergraduate, for every topic, there will be a 20 minutes discussion, lecture by the esteemed faculty. After that, the student will present the case and there will be a discussion. But the postgraduates, the continuous discussion is there. We do not want to divide this, and we'll have only a half an hour for you for the lunch time also. So make it as quick as possible. And this day is for a learning. And whatever the doubts you have, whatever the things you have in the question, please feel free to ask. And all the examiners here, all our seasoned examiners, so they will be there to help you at any time. So make this opportunity and to see that. And I'm so happy because the last 2 sessions what we have seen, and all of you have done extremely well. So I'm sure this trend will continue. That will be uplift the image of all of our medical students in the medical colleges. And also this is also an opportunity to thank the professor of the HOD of the Velamal Medical College, Damodaran sir, for sending the students from Velamal Medical College. Professor and HOD Dr. Soundararajan from Mogambiya Medical College for sending the students, and from Tuticorin, Tirunelveli and Madurai, and some of the students has come from even far off country, So I thank all of you for all the HODs for sending them here. Thank you very much for this opportunity.
Professor Dr. Angeline Vincent ma'am also onto the dais.
I invite our medical superintendent, Dr. Kingsley Jabasingh sir, to light the lamp. Our vice principal,
I kindly request the guest faculties also onto the dais. Please, sir. Thank you, everyone. We take this opportunity to welcome our esteemed Dean, ma'am, Dr. V. Ramalakshmi, ma'am, to address the gathering. To inaugurate the official ceremony of Twin CME and for the Chief Guest address. Please, ma'am.
Morning to all. Respected Medical Superintendent, respected Vice Principal, and respected Professor Dr. Jayalal, and the ARMOs Vijay Lakshmi Madam and Nimol, and professors in our department, in our college, and other faculties, and eminent speakers from the various colleges, medical colleges, and the students, UGs and PGs. I am very happy to see all of you, the full of hall attendance. And I also thank Dr. Jayalal for organizing this CME program to mark the occasion of Pink October. Yesterday also we celebrated the awareness rally and awareness talk in front of the OPD to celebrate the Cancer Month. So it makes awareness, and also the CME is also conducted to mark this occasion. And we, the doctors, are lifelong learners, all of us know. New diseases will come, new diagnostic techniques, and the treatment modalities, so everything will come and change. So to meet out this, doctors, we should have these CME programs. That is the importance of this significance of this program. So you students, from now itself, from UG, PG, or even you become the doctor, so we should update our knowledges. So we should develop our skills by attending this wonderful and innovating CME programs, not only in our state, in other states, nationwide state conferences and nationwide conferences. So you should update your knowledge by attending this promptly. So nowadays, patients know more than us. They will ask so many questions. So you should update. So I wish you all the best for attending this CME program and also for your exams. So I hope this CME will give you knowledge for you. So I thank the opportunity and I finish my address. Thank you.
Request our Medical Superintendent, Dr. Y. Kingsley Jabasingh sir, to felicitate the function.
Good morning to the dignitaries on the days and off the days, and my dear students. First of all, I am very thankful to Department of Surgery and HOD and the faculties for giving me this opportunity. Here I am able to witness the CME is wonderfully arranged, and it has a 2 parallel session on par with conferences. We also have eminent professors as well as teachers as a faculty, and I think it is a very good opportunity for the undergraduates as well as postgraduates to increase their knowledge and update their skills. We all know the medical profession needs a continuous update of knowledge, otherwise one day we will be outdated. So it is very important to have, as well as it is very useful to you also. Here the sessions are wonderfully arranged by under the eminent leadership of Professor Dr. Jayalal with the support of the other professors as well as faculties. I hope this will be very useful to all the faculties as well as students, both UG as well as postgraduates. I wish them all success. Thank you.
Good morning. Most respected Dean of Kanyakumari Government Medical College, Professor Ramalakshmi Madam. The Medical Superintendent, Professor Kingsley Sir. The HOD, the most dynamic HOD of our Kanyakumari Medical College, அவர் தான் நினைக்கிறேன். ஸோ அவர் பேரை சொன்னாலே சும்மா அதிருதில்லைங்கிற மாதிரி தான். ஜெயலலிதா சார்னா இன்றைக்கி நேஷ்னல் மெடிக்கல் கமிஷன் ஆனாலும் சரி, ஐஎம்ஏ ஆனாலும் சரி, இன்றைக்கி it has gone up to the level of the Commonwealth Association, Medical Association. So he is a person who is always a pride for Kanyakumari Government Medical College. And the department also has been excelling under his able dynamic leadership. He is a man of not only words but of action. So we have observed him performing in so many platforms, and today this is one of the witness to this program. I think the undergraduate students of this batch of 2020 have done a great stimulation. Already அவரே ஸ்டிமுலேட் ஆகி தான் இருப்பார். அவரை போய் நீங்கள் ஸ்டிமுலேட் பண்ணியிருக்கீங்க, எங்களுக்கு கல்வி அறிவு வேணும்னு சொல்லிட்டு. ஸோ சாரும் உடனே தேசிய அளவிலிருந்து மாநில அளவிலிருந்து பல்வேறு இடங்கள்லேருந்து தலை சிறந்த நிபுணர்களை உங்கள் முன்னால் அலங்கரித்து இந்த நிகழ்ச்சியை சிறப்பான முறையில் நடத்தணும்னு சொல்லி சாரும் முயற்சி எடுத்திருக்கிறாரு. உண்மையிலே ஐ எக்ஸ்பெக்ட் அவர் ஸ்டூடெண்ட்ஸ் டு கெட் ஹானர்ஸ் இன் சர்ஜரி. ஸோ ஆஃப்டர் திஸ் ப்ரோக்ராம் there is no question of telling I got pass. You have to get honors in surgery. That's one request. And many of you should take masters in surgery departments. Okay, this is my wish. I wholeheartedly appreciate Professor Jailal sir and the entire team of Dynamic, Dr. Bhagavat sir, Dr. Edward King sir, and then our Suresh Manigandan, and our Selvin sir, AJIN MANOVAH sir, அங்கே பின்னால் போய் நிற்கிறாரு, ANGELINE madam. Entire department surgery was always a bandwagon of Professor Jailal sir, and they are doing a great job. Once again, wish this program a great success for both the UGs and the PGs. It will be fruitful for you, and may God bless you all. Thank you very much for this opportunity.
Professor and HOD, Department of General Surgery, Professor J. Jailal sir, to honor our esteemed Dean, Dr. V. Ramalakshmi ma'am. Ma'am, please.
Now I request Dr. ANGELINE VINCENT ma'am, Associate Professor of General Surgery, to honor our Medical Superintendent, Dr. Y. Kingsley Jabasing sir.
Now we request Dr. Selvin J. Kumar sir, Associate Professor of General Surgery, to honor our Vice Principal, Dr. K.U. Suresh Balan sir.
Dr. Renimol ma'am and Dr. Vijay Lakshmi ma'am. Now we take this opportunity to honor our eminent faculties. May I request our respected Dean ma'am to invite Professor Dr. Alex Edwards sir onto the dais, Professor of General Surgery from Sri Mookambika Medical College. Now I would like to invite may I request Professor Dr. Punitha sir, Professor and HOD General Surgery from CSI Mission Medical College onto the dais. We wholeheartedly welcome Professor Dr. R.C. Srikumar sir, Vascular Surgeon and Professor of Surgery from Trivandrum Government Medical College. May I request Professor Dr. Dayananda Babu sir, Professor Emeritus Surgery from Sri Gokulam Medical College, Trivandrum, onto the dais.
Thank you, ma'am. Now I humbly request Professor Dr. ANGELINE VINCENT ma'am for the vote of thanks.
Our dignitaries on the dais, our Honorable Dean, Professor Ramalakshmi ma'am, our Medical Superintendent, Dr. Kingsley, our VP, Professor Suresh Balan sir, our ARMOs, Dr. Vijay Lakshmi ma'am and Dr. Renimol ma'am, and our dynamic professor who is the man behind this event, Professor Jailal. He needs no introduction, and I also thank all our eminent professors, Professor Alex Edwards sir, Professor Sri Kumar sir, Professor Punithan, Professor Dayananda Babu sir, and all our other professors from this college. I thank you all for gracing this occasion and contributing to this academic extravaganza. Thank you.
Back, it was sudden onset of dull aching type of pain, and it is intermittent in nature, not referred pain, and it is not associated with food intake. Then coming to the vomiting, history of vomiting is for past 3 months. Initially it was 1 hour after food intake, then it is progressed to immediately after food intake. It contains partially digested food particles, non-bilious and non-projectile vomiting. It is not blood stain, and it is not foul smelling. It is not relieved by the medications. And a positive history of ball rolling movement is present in the upper abdomen. In history of early satiety, loss of appetite and loss of weight is present. History of easy fatigability is present. Negative. Then past history, there is no history of similar complaints in the past and no significant past history.
So usually in the examination, every now and then we will intervene. So now we are not intervening because of want of time, because of Punidan, Dr. Punidan. Yeah. So at the end of the time we will intervene. Right.
Then personal history, he consumed mixed diet. History of smoking is present for past 40 years. He smokes 1 pack per day, that is 20 BDs per day. No history of alcohol or drug allergy. No family history suggestive of any malignant related death in the family members. Summary, 55-year-old male patient presented with intermittent type of dull aching abdominal pain for past 3 months and non-bilious vomiting immediately following food intake for past 3 months associated with the loss of appetite and loss of weight. History of ball rolling movement is present in the upper abdomen. No significant family and past history. Probably a case of gastric outlet obstruction. Examination. Then examination. After
So
explaining
in the summary, one minute. We will discuss a little about the smoking.
So smoking is one of the risk factor for carcinoma stomach.
Okay, then any type of food intake?
Sir, food intake, any spicy food intake or smoked food intake, excessive salt will cause predisposed to CA stomachs.
So the incidence of carcinoma stomach is increasing or decreasing now globally and in India?
Due to more diagnostic tests it is increasing, but due to refrigerator invention it is decreasing.
Okay.
Due to H. pylori decreasing.
Proximal stomach or distal stomach?
Distal stomach.
No. Distal stomach rate of malignancy is coming down because of your PPI, this thing, all other things. So proximal is on increase because of your Coke and items. Never drink Coke. All of you. If you want to drink, what is the ideal drink you can take?
Tender coconut.
Tender coconut. And Veranama? Sorry, proceed.
Right. See, alcohol also it was in the history.
No history of alcohol.
No history of alcohol. Oh, not an alcoholic. Okay.
Examination. After explaining the procedure.
So the importance of vomiting. So vomiting is more important or vomitus is more important? Which is more important?
Sir, both are more important.
Vomitus. The content of vomiting is very important. Whether it is partially digested or totally indigested or
bilious or non-bilious.
Those items are important. So not the vomiting is important, but what is more important is the vomitus. There is a content of vomiting.
Examination. General examination. After explaining the
And
procedure.
she told something about the family history. Now you should know little about the genetic. Some genes are involved. Okay. Sometimes if you answer well, they may ask.
E-cadherin gene mutation. Like familial adenomatous polyposis.
Okay, right.
Nephronis.
I hope you all know all this. And you look very bright. Right.
General examination. Patient was comfortable and cooperative, moderately built and poorly nourished. No loss of skin turgor. Pallor is present, no icterus, no cyanosis, no clubbing, pale edema or generalized lymphadenopathy. Vitals, BP is 110 per 70 mm mercury in left upper arm. Pulse rate is 88 beats per minute. Temperature is afebrile and the respiratory rate is 15 breaths per minute.
So what is more important in general examination in your case? What is more important? Sure, nutritional status, hydration,
due to excessive loss
and
of
build of the patient. Built. Okay.
What is built, ma? What is nourishment?
Sir, built is a skeletal framework of the patient and nourishment is the muscle mass.
Yeah, soft tissue mass.
Have you calculated his BMI?
Yes, sir. It is about 19.
19.
Yes.
Okay.
Then inspection. There is a fullness seen in the epigastric region and visible gastric peristalsis is seen. Umbilicus is midline and it is inverted. No nodule seen around the umbilicus. All quadrants are moves equally with respiration. Skin over the abdomen is
So you
normal.
have put inspection, the fullness is in the epigastric region, visible gastric peristalsis is seen. From where you will look for the visible gastric peristalsis. So usually what is the position of the patient and position of the examiner? Normally in inspection,
Sir, inspection. Patient is in supine position.
supine position, of course. You
We
stand
should
on the
stand on the right side of
right
the
side of the patient, right. What about the VGP? Examination of VGP and VIP
It
should be examined at the foot end of the patient. The time when you stand at the foot end of the patient and straight away look or some angle
Sir, angle like at the level of abdomen.
at the level of stomach.
Longitudinal.
Okay, okay. You bend little, don't bend too much, right? Okay. Tangential angle, it's about 15 degree, 15 to 20 degree you bend. Then you look for then only you will be able to see the waveform movement above the umbilicus, left to right. Then if it is below the umbilicus, right to left, small waves, it is intestinal peristalsis, okay? So you should know the difference between VGP and VIP. You know, ma? Right.
Then on head raising test, the mass become less prominent and there is no fullness seen in the left supraclavicular fossa or left axilla or in the renal angle. External genitalia appears normal and the hernial orifices appear normal. On palpation, there is no local rise in temperature and it is not tender. Abdomen is not tender. A vague mass of 5 cross 3 cm is noted in the epigastric region, 2 cm from the xiphisternum and 3 cm above the umbilicus. Left border is at the midline and the right border is seen in the right mid-clavicular line. And the margins are ill-defined and it is smooth surface. The mass is smooth with respiration, it is firm in consistency and liver and spleen are not palpable.
So the movement with the respiration is inspectory finding or palpatory finding?
Inspection. Both inspection.
Both inspection and palpation. Very good.
On percussion, impaired resonant note is adhered over the mass and no shifting dullness. Other region of the abdomen are tympanic on percussion. On auscultation, normal bowel sounds are heard, succussion splash heard. Ausculter percussion, the greater curvature of stomach is lies 2 cm below the umbilicus.
Distended stomach.
Yes, sir, distended.
Then with mass also.
Yes.
Oh.
So
mass, yeah.
Epigastric quadrant, epigastric region. Yes,
what about the upper limit of the margin?
Sir, 2
You are able
cm
to
below
palpate
the
upper limit?
Sir, yes, sir. It is 2 cm below the xiphoid process.
Xiphisternum.
Yes, sir. Xiphisternum.
Okay, xiphoid process. Okay. Then what about the right side and left side? So right side of the mass is palpable, left side of the mass is palpable, or only and superior and inferior borders are palpable?
Sir, the right side are up to the midline. Sorry,
No,
left side
are you
are
able
up
to
to
palpate the mass and the right
Well
side?
defined, ma. All margins are well defined, or some margins are underneath the subcostal like that.
Not underneath the subcostal margin. It is superior border is palpable only.
So it is a well circumscribed mass. No, tell your finding. We'll discuss later.
Sir, it is not well like.
Mike.
Sir, 2 cm below the xiphisternum.
No, that is right. But what about on the right side? Mass na it has got a superior border, inferior,
medial, lateral, or right
or left. Yeah.
Yes, sir.
What about the right thing?
Right, mid-clavicular line. Up to the mid-clavicular line, it is extended.
Right. Left?
At the midline.
Midline.
So all margins are well defined. All margins are you are able to feel. So leave it.
Okay, right.
But you said stomach is distended. No, when there is, am I right? The stomach is 2 cm below the umbilicus.
Yes.
Such a huge dilated stomach and the mass.
Very
unlikely.
See, the dictum is when there is a mass, when there is a malignancy, stomach will not dilate too much because of the malignant cells will not allow the stomach to dilate. So a gross dilatation you will get only in chronic duodenal ulcer with
benign pathology.
Benign pathology. When there is obstruction, cicatrization, there you get hugely distended stomach. So
There you may not be able to feel a mass.
Yeah, there you
Only
may not be
distended
able to
stomach.
feel a mass. You understand? So either one is correct, either CA stomach or it is a chronic DU with, your finding may be wrong, this distended stomach. Mass we accept. Auscultation then.
Rectal examination, the sphincter tone was normal, no mass or nodule palpable. And
What nodule?
What are you looking for in PR?
You mean no mass, no nodule. What do you mean by a mass and what do you mean by a nodule? No fecal stain, normal fecal stain, no melena.
Bloomer shelf.
Yeah, you
the
specifically
malignant cell
look for the
deposit.
Bloomer, yeah.
Wow. Okay.
What
So
is melena? You said no melena. What is melena?
Sir, it is a black tarry, foul smelling sticky stools due to seen in upper GA hemorrhage.
Yeah, correct.
How will you make it? How will you confirm it is melena or not tarry stools due to some drugs? Some drugs also can produce melena.
Iron tablets and
Iron tablet, bismuth and all.
they
Yeah.
usually
How do you confirm it is
melena
melena?
will stick
This is
on
a common question which is asked in the examination. How will you confirm it is melena? Right? How will you confirm?
melena usually sticky stool, it will be stick on the toilet and it is
Other
not
one will
easily
not
flushed
stick.
out.
So you will have to put your hand inside and in the commode and see whether it will stick or not. No, not possible. Not possible.
Fouls
Confirm means you will have to do a confirmatory test.
Test ma.
Bedside test. Huh?
What you say is correct.
Pardon?
Sticky.
Benzidine test. Okay. You find out, right? So there is a test. Name of the test. What is the reagent? How do you do? Okay. Then.
Summary, a 55-year-old male patient who is chronic smoker and not an alcoholic presented with the chief complaints of intermittent type of dull aching abdominal pain for past 3 months and non-bilious vomiting immediately following food intake for past 3 months, associated with the history of ball rolling movement in the upper abdomen, loss of appetite and loss of weight. On examination, pallor is present, a vague mass of 5 × 3 cm noted in the epigastric region which is smooth on respiration. It is firm in consistency with the impaired resonance on percussion. Visible gastric peristalsis is seen over the upper abdomen and a succussion splash heard.
What's your diagnosis? Probable diagnosis?
It is a
Differential
case of
diagnosis?
gastric outlet obstruction, most probably due to carcinoma stomach.
Carcinoma stomach. Okay.
Which part of the stomach?
Pylorus,
Yeah.
distal part of stomach.
Be specific.
Pylorus stomach, pylorus part only will produce obstruction, whereas the body will not produce obstruction. Usually will not produce obstruction.
Okay. How will you confirm your diagnosis?
Sir, by doing
So I am telling it is a benign pathology. Why do you tell it's a malignancy?
so the first one is it is acute presentation. The duration is that 3 months.
So malignancy will have acute presentation.
Rapid growth will cause sudden.
No, what will be the presentation? Suppose if you label a patient as carcinoma stomach, so what are the things you will look for? Positive things.
So,
One is the age.
Age.
Yes.
He is 55. The malignancy most commonly occur in last
Okay.
4th decades.
Appearance.
It is he is poorly nourished,
Built.
sir.
Poorly nourished.
History of weight loss is present and loss of appetite is present. Then the vomiting, it is a
And the history wise, so you will have to confirm your diagnosis or come to your diagnosis according to your history, an examination and your diagnosis, probable diagnosis. So that's why you summarize all things. You have to summarize the history and the summarize the examination, then you come to your diagnosis. When diagnosis is not possible, you have to make a differential diagnosis. So diagnosis of gastric outlet obstruction is correct. The cause, we will have to find out what is the cause of the obstruction, whether it is benign or malignancy. Okay, right.
He has a history of non-bilious vomiting, sir, and has the history of ball rolling movement. So it is most probably a gastric outlet obstruction. And he has loss of appetite and loss of weight that can be due to carcinoma of stomach.
So the probable diagnosis from your history is carcinoma stomach.
Yes, sir.
That finding which supports carcinoma stomach is a mass in the epigastric region which moves with respiration. So with this you conclude your diagnosis as a carcinoma stomach as a first diagnosis. Second diagnosis, which is the differential diagnosis, you can tell is chronic duodenal ulcer with obstruction. So in that what would be the history in chronic DU?
Previous history of abdominal pain which has the periodicity and
Yeah, correct. Previously the periodicity of attack will be there. Now it become a continuous pain or continuous discomfort to the patient. Then
there will be usually the gastric ulcer will produce cicatrization and malignancy also. So food intake will aggravate
second
the pain.
patient will not have that much loss of appetite and loss of weight like in malignancy. They will not be cachexic. They will not be cachexic. Now how will you proceed? You'll do the treatment and go. How will you proceed?
Then we should do the basic investigations like
You always come to the point, investigation to confirm your diagnosis. Specific investigation?
specific endoscopic ultrasound.
Endoscopic ultrasound, no. Endoscopic ultrasound we don't do. How will you confirm carcinoma stomach? Never? Upper GI scopy and biopsy. Ultrasound illama. Ultrasound எப்ப பண்ணுவோம்? What is endoscopic ultrasound?
At the tip of endoscope there will be ultrasound
Probe.
probe
Yeah.
is there.
That is done for some other purpose. To find out early gastric carcinoma, to find out pancreatic. வாங்க. சார் உங்களை இன்ட்ரோடியூஸ் பண்ணுங்க. சார் இன்ட்ரோடியூஸ் பண்ணுங்க.
I'd like to introduce Rajkumar sir, who will be jointly chairing the session. He is past associate professor of our college surgery. Good morning, sir.
So we do upper GI scopy and biopsy. That is the investigation of choice. In biopsy, what is the common carcinoma? Commonest carcinoma in stomach?
Adenocarcinoma.
Adenocarcinoma. So once you confirm the diagnosis, then you go for other investigation. What investigation you do after the?
CECT.
Yeah, very good. Contrast enhanced CT to find out.
Nodal status of.
Yeah, to find out the extension of the lesion and nodal status, liver metastasis, ascites, para-aortic nodes, sometimes Krukenberg's tumor. So everything you can see in CT scan. So CT scan basically it is done for contrast enhanced CT scan is done for extension of the lesion, lymph node status, liver mets, ascites, para-aortic nodes as well as in the tumor in the ovary. Right? So once you do the extension, then you plan for surgery. What is operable carcinoma stomach? What is inoperable carcinoma stomach?
For operability, there should be no metastasis, no hematogenous metastasis, and it should be no distal peritoneal involvement.
Yeah, so there should not be any peritoneal metastasis, but there should not be multiple liver metastasis should be absent then.
Nodal N4, more than N4 is not operable condition.
What is more than N4?
N4?
Nodal status. No.
CA stomach N4? Directly asking, what are the signs of inoperability?
What are the signs of inoperability? Multiple liver mets.
Hematogenous spread to the liver and distal peritoneal metastasis.
Yes.
And if the tumor involves the inoperable organ, and we should not remove.
What are the organs?
Left supraclavicular node metastasis.
UGs.
Troisier sign, presence of
Ascites is absolute contraindication for surgery. Ascites is absolute contraindication. We cannot do anything when the patient is having gross ascites. Right? Then rectal shelf of Bloomer. Right? Then Irish node. supraclavicular node. These are all the things which you can say signs of inoperability. What will you do if it is operable? What is the treatment?
Sir, Billroth 2 surgery with...
Your patient, your patient is pylorus, am I right? Pyloric growth, which is adenocarcinoma. It is confined to the pylorus. No liver mets, no peritoneal mets, no ascites. So what is your plan?
So you told something about the nodes. How will you, what are the nodes in this carcinoma stomach?
Actually, there are 16 levels of
that's
nodes.
okay.
Are there.
Then what about N4? Why did you say it's something like N4? Oh, okay. You know the 16 levels are there. Okay, right. Okay. Then you answer this question.
Sir, Billroth 2 surgery with ROX NY anastomosis and D2 level node dissections.
Gastrectomy ne chollaliyamma. The answer is gastrectomy. After that only this anastomosis and all come. What gastrectomy you do for a pyloric lesion?
Subtotal.
Yes, we do subtotal gastrectomy. When do you do total gastrectomy?
If the tumor is present in the body.
Yeah. So subtotal and total gastrectomy are accepted terminology, accepted treatment for CA stomach. Subtotal 85 to 90% of the stomach is removed. Only the upper part, the close to the cardia, we leave a little bit. In the total gastrectomy, we remove everything. Reconstruction of anastomosis is done in 2 ways.
ROX.
Ru and Y.
Then,
and loop. Gastrojejunostomy. Am I right?
yes, sir.
What other investigations of interest you know? You told about the endoscopy, then you told about the CECT. Any other investigations you know?
PET scan. We can.
Before that, to see all the layers of the stomach.
You told no, for me, answer. One answer you told no. Endoscopic ultrasound. In early breast cancer, it has a very vital role. What is early breast cancer? What is early breast cancer? Sorry, early stomach cancer. Sorry. Wrong. Early stomach cancer. What is early gastric cancer?
Tumor is confined to the?
Tumor is confined to the mucosa and submucosa, with or without nodes. With or without nodes. They have very good prognosis. In Japan, they detect the lesion very early. They always detect the lesion by regular doing endoscopy in a early gastric cancer, so that their results are far better than Western countries and Indian. We usually here patients will present with the mass. So it's itself a inoperability. It's a widely spread tumor. It goes beyond the serosa. Then only we will be able to palpate the mass.
Okay, what are the procedures available for this early gastric cancers?
We can do distal gastrectomy.
Early gastric cancers. I told the endoscopy.
Endoscopic
No, we told that no, in Japan they detect the cancer earlier.
Yes. Sir, endoscopic resection can be done if it is less than
ultrasound.
No, that is the investigation.
Less than 1 centimeter. We can resection with
That is
marginal microscopic marginal clearance.
One is endoscopic. What we resect? Mucosal resection and submucosal
resection.
Dissection. That is submucosal is dissection. Mucosa is resection. Just to name the procedures, not more than that for you. Okay, right. Good.
Okay. Sorry. The another differential diagnosis is chronic duodenal obstruction with chronic duodenal obstruction. So here, when you put the scope, you will not be able to see any lesion, any mass. You will be the stomach is grossly dilated as if you are entering into the empty room. So you will not be able to see the mucosal fold at all. So you will have cicatrization. So that is treated by, there are 2-3 things method you can treat the duodenal obstruction. One is truncal vagotomy with gastrojejunostomy. That is one standard traditional procedure. Truncal vagotomy and GJ or pyloroplasty. Truncal vagotomy with GJ or pyloroplasty. The newer method, now what we, after the endoscopic era, you can dilate the pyloric stenosis with the balloon dilatation and give PPI, proton pump inhibitor. So if they go for re-occlusion, again we need to dilate. That is a without surgery we can. These are all the two methods. Right. So DU, the CA stomach is managed by subtotal or total gastrectomy with gastrojejunostomy or Roux-en-Y jejunostomy. In a chronic DU, it is managed by bilateral truncal vagotomy with GJ. Right? Very good.